Okay, the objective, this is where I want to start. These are going to be the main things we're going to be covering today. The first is to demonstrate basic anatomy of the hip. Now, that's something you're probably all familiar with here in this room, but I want to go through that in a number of ways. Being a radiologist, certainly spent a lot of time looking at radiographs, CT, MR, in addition to ultrasound. So I'm going to use a combination of all those modalities to show the important structures in the hip joint itself, and then some of the surrounding muscle as well. And taking all those together, we can really get a good appreciation of what these are. Get a sense of what we're looking at. Next, I'm going to go through a systematic approach to sonographic evaluation of the hip. The hip is like any other area that we're going to look at in MSK ultrasound. So we're going to divide up a very complex region into more digestible bits. We're going to evaluate the anterior hip extending down into the anterior thigh. Next, move to the lateral and then posterior portions of the hip, and also look at some of the important structures on the medial side as well. Discuss some common ultrasound-guided interventional procedures. In our practice at the University of Colorado, this is commonly how we're using ultrasound, actually, is to guide intervention, either an injection of the hip joint itself, iliopsoas, bursa injection, trochanteric bursa injection, a number of procedures that are possible with ultrasound. So I'm going to give you a couple of examples of what we commonly do, and then a few other examples of more infrequently performed procedures that give you an idea of how flexible ultrasound is in guiding intervention around the hip. Finally, we're going to demonstrate normal imaging appearance in real time. We're going to do that with a scanning demonstration here at the conclusion of these slides. I also want to call your attention to the hands-on session that takes place later in the AIOM meeting, where you'll get a chance to do some scanning yourself. Okay, so starting with diagnostic hip ultrasound. Again, divide the hip and surrounding region into really four major areas. This is how I approach the hip. Anteriorly, we're going to look at the hip joint itself, including the femoral head and neck, the acetabulum, the labrum, some of the structures that we can see along the anterior margin. I'm going to look at some of the anterior hip muscles as well. So as soon as you put a transducer on the hip, you'll see that in addition to the joint, there are several important muscular structures that are more superficial that we'll want to evaluate over the hip joint, also at their proximal origins, and I'll point out some of the important bony landmarks that we can use to identify those structures, and then follow those down into the anterior thigh. After that, we will change gears and look at the structures on the lateral aspect of the hip, focusing on some important bony landmarks that we can see at the greater trochanter. We'll evaluate the gluteus minimus and medius tendons, as well as the overlying tensor fasciae lata muscle, gluteus maximus, and the fascia lata as it extends down into the iliotibial band. On the medial side, we'll look at the adductor musculature, as well as the continuation of sartorius and gracilis muscles. I'm not going to spend a lot of time talking about the inguinal region, but a few important landmarks that I do want to point out include the rectus abdominis muscle, inferior epigastric artery, some of the structures that we're going to use to identify the presence of a hernia. And again, I'm not going to go into great detail with that, but you do want to be aware of those structures in case you encounter a hernia as a possible source of a patient's anterior hip pain. Finally, we're going to focus on the posterior hip, namely the hamstring origins and the sciatic nerve. Preview some of the injections we're going to talk about. Hip joint injection. I'll demonstrate some of the planes and how we'd set up the transducer to do that procedure. We'll do that here and also in the demonstration. Iliopsoas bursa injection. This is probably the most common procedure that we do with ultrasound guidance in our clinic, so I'll spend some time talking about that. Trochanteric bursa injection, again, commonly performed procedure. I'm going to spend a few minutes also talking about hamstring origin injection, specifically a case where we did a PRP injection and gluteus medius calcific tendonitis lavage. Again, not an exhaustive list of what's possible in and around the hip, but just a nice set of examples showing some of the flexibility of ultrasound. All right, so I'm going to start with a couple important points to consider. In most cases, when we're doing ultrasound of the hip, we're really trying to answer a specific question. So we're targeting our search to a particular area, and that might just be the anterior hip or just the lateral hip, and that's really guided by the patient's symptoms. So compared with an MR study, for instance, where we get a real global evaluation of the hip, ultrasound, we're really trying to home in on the specific structures that are likely responsible for a patient's symptoms. One of the nice things about ultrasound, which I'm sure you're all aware of, is when you're there scanning the patient, you have direct access to that patient. You can ask them questions about their history, how long they've had pain, if there's certain maneuvers that bring on their pain. All of that's important information that you want to take note of to try to arrive at your diagnosis and to direct where you're putting the transducer. So commonly I'll ask a patient where their symptoms are, have them point to that area, and in addition to evaluating all the standard structures at each of these locations, try to figure out if there's any anatomic correlate to what they're describing as their symptom. Transducers. So we use a combination of high and low frequency transducers to evaluate the hip. And this is also a little bit different than the approach we take when evaluating other joints. The hip joint is a pretty deep structure. So in some patients, particularly those with who are more obese, you're really going to need a higher frequency transducer to get adequate penetration to see the necessary structures. So commonly I'll begin with a low frequency transducer, make sure we've got everything included that we need to see, and then move on to a high frequency transducer to evaluate the more superficial structures, such as the muscles that run over the anterior margin of the hip. Comparison with other imaging modalities is helpful. It's really critical, actually. So before we do any kind of hip ultrasound, I'll look through our packs and come up and find whatever imaging studies we have available. Radiographs, CT, MR, really any study that we have is going to provide a lot of important information. Some examples would be, for instance, if a patient has had a hip arthroplasty, that's going to be critical information to know before beginning your ultrasound. If there's a specific area or old fracture or old injury, all of those are going to be useful bits of information before you embark on doing the ultrasound study. Okay, so what I'm going to do now is go through each of the major regions of interest, again, anterior, lateral, posterior, and medial. And the way I have these slides set up is a little model here in the posterior, or in the top of the slide, showing where the transducer is going to be placed with respect to the patient. I'm going to talk about some of the specific structures that can be seen at each of the locations we're going to cover, and then include a few notes about patient positioning and how that varies depending on the structure that we're evaluating, and also a few words about what transducer we might want to use. All right, we'll start with diagnostic evaluation of the anterior hip. So you can see actually for the first image here, I just have a few MR images, coronal and oblique axial image, T1 weighted. The reason I have this up is to show just the number of structures we're seeking to evaluate when we look at the anterior hip. There's obviously the bone and the capsule of the joint, as well as multiple muscle structures that are more superficial to that. So we're going to use, again, a combination of transducers to get a look at all of these structures. For the anterior hip examination, the patient is positioned supine with their leg straight ahead. Transducers, typically I'll start with a low frequency transducer, make sure that everything can be adequately evaluated, and then as appropriate move on to a higher frequency transducer such as the 12 megahertz linear transducer. All right, I'm going to start by talking about the hip joint. So where do we start with the examination? That's another important topic to go over. It can be a little intimidating when you're looking at structures like this for the first time, where there are multiple muscles, complex bony anatomy. It's important to find a place on the patient where you really know where you are and start from there. The way I'll often do that is take a transducer in transverse plane to the patient and place that on the femoral shaft. So in the diaphysis of the femur, it's easily identifiable as a bright echogenic surface, and you can follow that proximally into the trochanteric region, and then from there into the femoral head neck region. Once you get there, you want to turn the transducer so that it's longitudinal, and several important structures are all laid out when you have the transducer in that position. So on a corresponding MRI image, you can see examples of both low frequency and high frequency images of the hip joint itself. So on the image below here, you can see the echogenic margin of the acetabulum, the femoral head, and femoral neck. Some important structures to point out here are the thick capsule of the hip joint, the bright echogenic surface of the femoral head cortex. There's a very thin line of anechoic cartilage, which we actually see much better with a high frequency transducer as well. So compare that to the image above. Here you can see our spatial resolution has improved quite a bit. You can see that thickened, in this case normal thick capsule. Again, the bone surface, and then that hypoechoic or even anechoic layer of hyaline cartilage. And important to recognize that appearance, and several of the other speakers this morning described that as well, and not to misinterpret that for the presence of fluid. After evaluating the hip joint in the longitudinal plane, turn the transducer 90 degrees and obtain some transverse images. This is a localization image on MR, giving you an idea of where we are here, and that this is the femoral head with the bone. You can see again the cartilage and the capsule, and just coming into view here is the highly organized echogenic structure of the iliopsoas tendon. I'm going to talk about that a little bit greater detail here in just a moment. All right, some other structures that are visible at the anterior hip joint include the labrum. Not easily seen in all patients, but in a thin patient with a high frequency transducer, we can actually make out that very bright echogenic triangular structure of the anterior labrum. So whenever we can see the labrum, we certainly take a look for a tear or detachment. Again, MR is really the imaging study of choice for evaluating the labrum, but certainly we get a good look at it by ultrasound in some cases. So it definitely makes sense to take a look as you may encounter pathology there. All right, the anterior joint recess. This is an important structure that we are evaluating in the anterior hip. So here I have two different patients, both with an MRI and corresponding ultrasound images of that region of the femoral head neck extending down to the anterior joint recess. So as you follow down from the femoral head into the femoral neck, you'll see the thickened anterior capsule. It's redundant, and in most patients it's completely collapsed. You really don't see any detectable fluid in that location at all. Compare that to a patient here who has a hip effusion, and you can see that anterior margin of the capsule is elevated. On the MRI, you can easily see the fluid here, and ultrasound shows the same finding. So the capsule is thickened, it's a little bit elevated here, and then there's this anechoic layer behind that. So physiologic fluid in the anterior joint recess, 2 millimeters is the measurement actually that we use mostly in pediatric patients. So if you see more than that in a child, good indication that there's an effusion present. In an adult, it's a little bit more challenging to tell. Often at this kind of depth, it can be difficult in some cases to actually distinguish between fluid, synovitis, and the capsule itself. So thickening more than about 7 millimeters or significant asymmetry compared to the opposite side, more than a millimeter, is a sign that we'll sometimes use. So important to be aware of that pitfall, particularly in more obese patients. Getting adequate penetration to look at the anterior joint recess can be a little bit challenging. All right, moving on to the iliopsoas tendon. This is a structure that we spend a fair amount of time evaluating with ultrasound for a couple of reasons. Injury to the iliopsoas tendon, such as tendinosis and bursitis in and around the tendon, are common causes of anterior hip pain. You see that sometimes in patients who are involved in athletics, and it's also a common cause of anterior hip pain in patients who have undergone a hip replacement. These are two transverse images of the iliopsoas tendon. You can see its bright echogenic architecture. Just above the hip, you can see the muscle fibers of iliacus and psoas that are both contributing to its structure. And as you follow the iliopsoas tendon a little bit distal, you'll see fewer muscle fibers and more organized collagen of the tendon itself. This is the same structure shown in longitudinal orientation of the transducer. And I like this slide because it illustrates a couple important points about MSK ultrasound in general. The main one being anisotropy, again described by several of the speakers earlier, and something really to be aware of whenever you're performing MSK ultrasound studies. Here where the sound beam is perpendicular, the structure is very well seen, brightly echogenic, but you can see on the proximal and the distal margins, it's really becoming more anechoic. So important when you're looking at a structure like this that's curving as you follow it, that you're really trying to follow that with the transducer. That brings up another important technical point as well, actually. With the way you want to hold the transducer when you're evaluating a patient is with usually I'll just use my index and long finger and thumb to hold the transducer, and my small finger and ring finger will be kind of right down on the patient, holding the transducer against the structure that I'm evaluating. And in that way, you can toggle the transducer, rock it back and forth, do whatever you need to do to really follow these complex structures as they curve over the bony anatomy. So to go back one slide, another issue with the iliopsoas tendon, and the reason why we're commonly evaluating it, is for evaluation of a snapping hip. This is symptoms that patients typically describe are, a painful or even audible clunk or click with certain activities, sometimes just walking. A couple of things that can cause that. Some are intra-articular and are not going to be well demonstrated with ultrasound. So if the patient has a cartilage flap or a labral tear, in some cases we're not going to get a good look at that with ultrasound. However, a common cause is an internal snapping hip that's extra-articular in origin, and that's frequently the result of the iliopsoas tendon rubbing over the iliopectineal eminence on the pelvis, so just superior to the hip joint itself. If the patient's reporting that as their symptom and can localize that as an area of pain, I'll ask them to reproduce whatever motion it is that causes that symptom. And again, I have my hand and the transducer right on the patient at that area, so I'm feeling for any palpable clunk, and sometimes you can actually hear it as well while you're doing the examination. If they're not able to elicit their symptoms easily by just trying to reproduce whatever motion it is, there's another dynamic motion you can do with the patient. For that, again, having them supine, I'll have them bring their knee up, externally rotate their hip, and abduct their hip a little bit into a frog leg position. Again, keeping the transducer on the iliopsoas tendon, and from that location, have them straighten their leg, and often that will reproduce that same abnormal subluxation of the iliopsoas tendon. You also want to look for the presence of bursitis at this location. This is an example of a normal tendon right up against the bright echogenic surface of the acetabulum posterior to it. If the patient does have bursitis, you'll see fluid that accumulates posterior and often a little bit medial and lateral to the tendon. All right, I'm going to move on to some of the anterior muscular structures that you'll encounter in the anterior hip. But before we do that, I want to point out a few important bony landmarks that we're going to use to orient ourselves to the pelvis and the anterior hip. Namely the anterior superior and anterior inferior iliac spine. So these are bony protuberances along the anterior margin of the pelvis. When we're evaluating with ultrasound, commonly I'll palpate this area and try to identify these structures. Of course, you can bring the transducer and just kind of scan over that area. And the anterior superior iliac spine in particular is typically just a little bit beneath the skin surface and readily identifiable. From there, you can scan down a little bit further and find the anterior inferior iliac spine. So from that location, the rectus femoris muscle originates. That's the most superficial muscle of the quadriceps group. You can see that it starts up above the hip joint. It has a long head, which is located just superficial to that bony prominence and well demonstrated with ultrasound. And then an indirect head, which is a little bit more obliquely oriented. It's a little more posterior and inferior, a little bit more challenging to show that with ultrasound. But as you scroll down with the transducer, they both come into view, and you can see their contributions to the rectus femoris muscle belly. A little bit more superiorly, sartorius arises from the anterior superior iliac spine. So again, we want to find that superficial bony protuberance and then follow the sartorius down. That's the longest muscle in the body, so it's quite a long extent to follow the muscle in its entirety, but you can pick it up approximately right there at the anterior superior iliac spine. Bring the transducer a little bit more laterally. We'll get into the tensor fascia lata, which later on blends with the lateral fascia of the thigh. So we're going to look at that structure a little bit on the lateral side as well. So back to the rectus femoris for the moment. This is a sagittally oriented MR image. Again, localization of where our probe is. And arising from that bony prominence is the long head right here, rectus femoris. You can see it is, again, an organized hyperechoic structure. Turning the transducer 90 degrees, we can see the long head right here, superficial to the bone. And then with the indirect head, a little bit more challenging to see along the inferior and more posterior margin of the same bony structure. So that provides a nice segue into evaluation of the anterior thigh. We've seen the origin of the rectus femoris muscle. We can follow that down over the femur, and from there we're going to get into the quadriceps muscle group. Again, I'm just starting off here with a few MR images. This is a coronal MRI image with two axial images. And the reason I put this up is again to illustrate the fact that the muscle anatomy is complex and really changing quite a bit as we sweep down from the hip into the thigh. So again, numerous structures that we're going to want to evaluate. The patient is still in the same position, supine with the leg straight ahead. In most cases, we'll use a high-frequency transducer, and you just need to make sure that you're getting all the way down to where you can see the femoral cortex to be sure that you're evaluating the full extent of the quadriceps muscle group. So rectus femoris we already detected at its origin, superior to the hip. As we follow that muscle down into the anterior thigh, it's the most superficial of the quadriceps muscle group outlined here. Again, if you're starting in the thigh, you want to follow that all the way up to its proximal origin at the anterior inferior iliac spine. Vastus medialis originates from the femur. It's obviously a little bit more medial, deep to the rectus femoris, and we want to evaluate that structure. Next, the vastus intermedius. So this is the deepest of the quadriceps muscles. You can see the easily identifiable landmark of the femoral diaphysis here. If you turn the transducer from a transverse plane, which is where we are here, to a longitudinal plane, you'll see this fascial plane that separates the more superficial rectus femoris from the underlying vastus intermedius, and then the bright echogenic surface of the femoral cortex, and then just shadowing beyond that. These slides also demonstrate the normal appearance of the muscle architecture that we're looking for, which is primarily hypoechoic with a few visible septations. So muscle tear, either partial, typically a partial tear will manifest as loss of that normal architecture and some swelling and potentially more hypoechoic areas of swelling, whereas a complete muscle tear, often you'll see discontinuity of the fibers and a more heterogeneous appearance of the echotexture related to the presence of hematoma. Next, we'll look at vastus lateralis. Again, just by bringing the transducer still oriented transversely to the patient, a little bit more over to the lateral side, and that muscle will come into view. As you follow those structures down to the superior margin of the patella, they all give their contributions to the patellar tendon. And the patellar tendon was covered earlier in the talk about the knee, so I'm not going to go into that, other than to say that you really want to follow those structures all the way down to their through their distal extent to make sure that they're completely evaluated. All right, so from here I'm going to move to evaluation of the lateral hip. Several structures here that are important to consider. The musculature includes gluteus minimus, medius, and maximus, which we'll discuss, as well as tensor fasciae lata, and then some of the bursal structures as well. So when we're evaluating the lateral hip, we're going to change the position that the patient is in. Here I have listed supine with the hip raised. In most cases, actually, we'll roll the patient so that the side we're evaluating is up. So they're in a decubitus position, symptomatic side up. Sometimes we'll do some combination halfway between that and supine, depending on the patient's level of discomfort. But if you can have those structures that you're looking at really up and easily accessible, that's the way you want to go in most cases. Transducer that we're going to use, 12 megahertz high frequency transducer if possible. In some more obese patients, you may need to use a lower frequency transducer, but usually you can get by pretty well with a high frequency transducer in this location. Again, I'm going to talk about some of the important bony landmarks. So when I start evaluation of the lateral hip, have the patient right there talking with them, eliciting any symptoms that they have. I'll palpate the area and find the greater tuberosity or greater trochanter. The other thing you can do is place the transducer on the patient's lateral thigh, like we did anteriorly, identify the femur, and then just track superiorly until the greater trochanter comes into view. When it does, you'll notice a couple of important bony landmarks that are really going to help you orient to where you are. The different facets on the greater trochanter serve as the attachment sites for the gluteus minimus and medius tendons. So anteriorly is the anterior facet. It has a concave appearance that lends itself to identification by ultrasound. As you bring the transducer along more posteriorly, the lateral facet and the supraposterior facet come into view. And those are both sites of attachment for gluteus medius. So I'm going to talk about each of those muscles individually. Gluteus minimus is located anteriorly, again coming down to the anterior facet. More superficial to that is going to be gluteus medius, which is larger and has these two sites of tendon insertion on the lateral and posterior facets. Gluteus maximus, larger muscle, more posterior, overlying the posterior margin of gluteus medius. And along its anterior margin, you want to look at the thickened fascia, which also runs over the lateral margin of the greater trochanter. Okay, so again, once we're scanning, we've identified the greater trochanter as well as the anterior facet, where we're going to pick up the tendon of the gluteus minimus, and then bringing the transducer around a little bit more posteriorly, contributions from the gluteus medius. So this is a more proximal MRI image, and then more distally at the site of attachment of those tendons. After evaluation in the transverse plane, want to turn the transducer so that you're coronally oriented or longitudinal to these structures. Again, gluteus minimus is going to be more anterior. It can be a little confusing in some cases because the tendon of gluteus minimus comes down, attaches to that anterior facet, and you'll see muscle fibers superficial to it, which are part of gluteus medius. So important that you're resolving those two structures. More posteriorly, this is a corresponding MR image, again moving posteriorly. You'll see the tendon insertions of gluteus medius come into view right here. More superficial to that is the thickened fascia, fascia lata coming down into the IT band. So those are going to be your landmarks on the lateral part of the thigh. The tensor fascia lata, we mentioned this muscle earlier when we talked about the anterior hip arising from the lateral margin of the anterior superior iliac spine. It has a relatively characteristic appearance on MR and frequently on ultrasound as well. So you notice here on this corresponding T1 weighted MR image that there's some bright areas within the muscle, and it often has a higher fat content than some of the surrounding muscles. So in addition to using the bony landmarks, that appearance, which makes it a little bit hyperechoic on ultrasound, can lend in its identification. You also want to use your appropriate landmarks, such as the rectus femoris, which you'll see along its anterior margin, demonstrated here on the MR image as well. So next we'll talk about some of the bursal structures at the lateral hip. The greater trochanteric bursa, probably the most important and what we spend a fair amount of time evaluating and injecting. It lies along the superior, or the more superficial margin of the gluteus medius tendon and deep to the gluteus maximus and that thickened fascial layer. So kind of right in here. In most patients, there's going to be no detectable fluid in that location, and that's even the case in some patients who do have bursitis and have symptoms that are referable to that area. So again, when I'm scanning the patient, I'm asking them if the transducer is over a tender area, applying a fair amount of pressure as well and trying to reproduce their symptoms and use that as a way to guide where I'm going to do my injection. Gluteus medius bursa, another area that we sometimes inject deep to the gluteus medius tendon itself, and where that can rub over the bone of the greater trochanter. All right, with that I'm going to move to the medial hip. A number of structures here that we want to consider. These include the neurovascular structures, so the femoral artery, nerve, and vein, readily identifiable, particularly the artery and vein really jump out as anechoic structures. Next, we're going to look at sartorius, which we saw the proximal portion of that, but we're going to follow that a little bit more distally all the way down to the tibia. Gracilis as well, even a little bit more medially, and then the adductor musculature, and we'll have a few slides showing the appearance of each of those structures as well. So we've positioned the patient a couple of different ways so far. The medial hip actually has its own way you typically want to arrange the patient as well. So in most cases, we'll turn them back to a supine position, but now we have the leg abducted and externally rotated again into kind of a frog leg position, and that'll make the adductor musculature in particular lay out and be a little bit more easy to identify. Combination of transducers may be used, again, partially dictated by the patient's body habitus. In most cases, though, we can get pretty good images with a high-frequency transducer at this location. All right, so identification of the neurovascular structures, good place to begin. Easily identifiable structures, often evaluated for other types of examinations, including vascular studies, but they also serve as an important landmark, which we'll talk about in a moment. Okay, so the sartorius. Again, we talked about its origin more proximally A nice way to pick up the sartorius further down from the hip and into the medial thigh is that it forms a little roof under which the femoral artery is visible. So if you place the transducer on the medial thigh, look for that muscle right above those structures, and then you can follow its course proximally to the anterior superior iliac spine or inferiorly all the way down to the proximal tibia. Gracilis is visible a little bit more along the medial portion of the thigh. Again, it's going to be a very superficial structure. And deep to that, we're going to get into the adductor musculature. So again, we have the patient in that kind of frog leg orientation. The most superficial muscle that we're going to see is adductor longus, and this is an important muscle to consider. I mean, it's in its own right, but it also has a aponeurotic plate that it shares with the rectus abdominis muscle. So if there are symptoms that are being described as athletic pubalgia, you certainly want to evaluate the proximal extent of this muscle where it originates from the pubic bone superiorly into the rectus abdominis, and see if the symptoms are referable to that area and if there's any disruption of its fascia or the muscle itself. Deep to adductor longus, you can see adductor brevis, and then adductor magnus as a deeper structure still. So again, patient positioning is really critical to get these three structures to really stack up like this and be easily identifiable. A few other structures in the medial hip that we want to spend some time talking about. I have listed here the inguinal ligament, lateral cutaneous nerve of the thigh. Again, we have the patient positioned sort of in that frog leg view, probably not supine, but it kind of depends. If we're looking at the inguinal ligament, you may need to put them more in sort of a straight leg position. Standing, in some cases, we'll use to look for the presence of an inguinal hernia. So some of the landmarks I want to talk about here. We found the neurovascular structures earlier, and if you have the transducer transversely oriented the patient and bring it a little bit proximally, you can find the lateral margin of the rectus abdominis muscle. Just deep to that is the inferior epigastric artery and some paired veins, and those are important structures to identify because they're going to serve as landmarks for where we're going to look for the presence of a hernia. So you want to follow these distally to their origin at the external epigastric artery or the external iliac artery, and make sure that there's no abnormal tissue or bowel extending anteriorly through the abdominal wall at that location. So again, not spending a lot of time talking about that area, but important to be aware as patient potentially could have a hernia as explanation for their symptoms. The inguinal ligament we can follow from the anterior superior iliac spine to the pubic bone. In males, we can also identify the spermatic cord in the same location. One other structure occasionally that we are asked to look for is the lateral cutaneous nerve of the thigh. And this is a small nerve that exits typically just beneath the inguinal ligament near the anterior superior iliac spine. So on the little model here, it's going to be right adjacent to that bone. It's a small structure and it's a little bit challenging to pick up if you just place the transducer on the patient. But if you keep it in that transverse plane, scan up and down, often you'll see it riding along the superficial margin of the muscles in that location. And that can aid its, make it a little bit more apparent. So here's a proximal image and slightly more distal. Patients who sometimes have sensory symptoms in their anterior and lateral thigh potentially have an injury to that nerve, and so in some cases we're asked to do an injection for both diagnostic and therapeutic purposes, where we can put a needle right next to the nerve, taking care not to touch the nerve with the needle, and inject a little bit of anesthetic at that location. All right, so next I'm going to move to the posterior hip. As you can imagine, we're going to reposition the patient for this part of the examination. They're going to be prone so that we can get at all the structures that we need. Again, I have some MR images, just giving you a general idea of what kind of muscular structures we're looking at and how they change going from the proximal hip more distally. Transducer selection, again, largely dependent on patient body habitus. If we can get away with using a high frequency transducer, we certainly will. All right, the first structures we're going to look at here are the hamstring muscles. So again, in the posterior hip, you want to start in a place where you can really identify where you are. The easiest way to do that, I think, posteriorly is to put the transducer in posterior or in a transverse orientation identify the superficial muscles there, which are going to be the hamstrings, and then bring the transducer proximally to its origin at the ischial tuberosity. So this is a corresponding MR image as well as ultrasound showing the origin of the hamstring muscles. And very proximally, it's actually difficult to resolve the origins of each of these three muscles from one another. The semimembranosus does have its own origin. It's a little bit more anterior in location, and the semitendinosus and biceps femoris share a common origin a little bit more posteriorly on the ischial tuberosity. The sciatic nerve also has a characteristic appearance as well, and we'll want to identify that structure for its own right, and also to avoid it if we're contemplating any injection posteriorly. Okay, so this is the origin of the hamstring muscles. You'll find that it's often somewhat hypoechoic in appearance. It can be a little bit difficult to distinguish that from tendinosis in some cases. Sometimes I'll take images of the opposite side as well and try to correlate the patient's symptoms to see if it's related to that area right there. Okay, after evaluation in the transverse plane, of course, we turn the transducer 90 degrees, obtain some longitudinal images as well. We're going to go through each of these briefly. They really change quite a bit in appearance as you move from proximal to distal throughout the thigh. So important to be aware of the changing morphology depending on where you have your transducer. Semimembranosus again has its own tendon origin. As you follow it distally, it stays as a well-defined tendon quite a ways into the posterior thigh. Eventually you start to see a few muscle fibers kind of coming off the lateral margin of the tendon, and by the time you're down near the knee, it's a large muscular structure. Semitendinosus and biceps femoris share this tendon origin with muscle fibers visible along both the medial and lateral margins. So this is still pretty proximal here. You can see on the MR image, and then surrounded by fat on the MR, here's the sciatic nerve, well demonstrated by ultrasound as well. So the sciatic nerve is another structure that is a good way to localize where you are in the posterior thigh. It really jumps out as a brightly echogenic appearance, sort of this honeycomb appearance that you'll see in transverse imaging. And as you scan up and down the posterior thigh, it doesn't change in caliber nearly as rapidly as you see some of the other structures. So important to identify that and not to confuse it for a tendon proximally, where on a single transverse image looks somewhat similar in terms of its echotexture. All right, following those structures a little bit more distally, semimembranosus here, still largely a tendon. Semitendinosus, however, we're into the muscle belly here on the medial side. Lateral to that is biceps femoris. And again, this serves as a good landmark for the sciatic nerve, which you can see tucked between those two structures in the transverse plane. All right, next I want to talk about ultrasound-guided intervention. So initially, we went through kind of the general approach to the hip. Now I'm going to focus on what we do a fair amount of in clinic, which is actually using ultrasound to guide intervention. So hip aspiration is where I'm going to begin. A number of reasons why we might do an injection or aspiration for possible infection, for analysis for the presence of crystals, for instance. We'll do these both for diagnostic purposes. Sometimes our orthopedic colleagues want to know if a patient's hip pain is coming from an intra-articular structure or something that's extra-articular. They'll ask us to just put anesthetic inside the joint. Sometimes, again, we're doing this for purely therapeutic purposes. So to access the hip, we again position the patient supine. Transducer we're going to use, again, dictated by body habitus. I frequently will use a 5 megahertz transducer even in a relatively thin patient because it shows the needle very well over a wide range of depths. This is a patient who came to us through the emergency department. She was pregnant and had an MRI which demonstrated an effusion, which you can see both here on the coronal and the axial images. Given her pregnant status, we certainly didn't want to do a fluoroscopy if we could avoid it, so chose to use ultrasound to evaluate her hip, which we did here. So this is a longitudinal image, like we saw earlier, with the femoral head and neck regions demonstrated. You can see the anterior echogenic portion of the capsule, and that's bowed out and convex, and that's abnormal. Typically that's flat or even a little bit concave, so this corresponds well to the effusion that we could see with MR. In addition, there's an anechoic fluid collection visible in the anterior recess. Okay, So again, I mentioned this 2 millimeter of fluid consistent with effusion. Again, we use that primarily in pediatric patients, but significant asymmetry compared to the opposite side. In this case, it was really not a question at all. We knew that the patient had an effusion before embarking on the procedure. So how do we do the actual injection? We keep the transducer in that same plane, showing the femoral head neck region. So again, we're in that longitudinal to the femoral head, and then guide the needle in with real-time guidance right to that central portion of the anterior recess. And you can see the bright echogenic needle tip here. We aspirated the fluid, and this patient did indeed have a septic hip. In cases where we're going for infection, we'll use a large gauge needle, as the contents of the joint may be thick and difficult to aspirate with a smaller gauge. So we'll use 18 gauge if there's any concern for infection. All right, moving on to the iliopsoas bursa injection. Again, a common procedure that we're asked to perform. Patient is positioned supine, just like for the last procedure. We do this sometimes for diagnostic purposes. So if a patient has anterior hip pain, it's unclear if it's coming from the iliopsoas, tendon, or bursa, or from the joint. Sometimes we'll just do anesthetic. In most cases, though, we're doing a combination of the two, injection with anesthetic and steroid. As a diagnostic maneuver, we see what the patient's symptoms are like both before and after the injection. We actually send them with a pain diary to keep track of their symptoms for several days after the injection, and hopefully to make them feel a little bit better at the same time. So we begin the examination with diagnostic evaluation of the iliopsoas tendon itself, looking for the collection or a possible collection of bursal fluid. Again, sometimes we see fluid that elevates the tendon a little bit, that extends medially and laterally. In other cases, there's really no detectable fluid at all in the iliopsoas bursa, and that doesn't mean that they're not having symptoms coming from that location. The way we set up for the procedure here is a little bit different. So after identifying the tendon, I turn the transducer so that it's transverse to the patient, and then come a little bit proximally. You have a nice landmark with the femoral head, and you want to bring the transducer proximally enough that the femoral head is out of view, and that ensures that you're looking at the tendon over where you can easily access the bursa. There's a nice bony backstop where you're going to be doing your injection. That also ensures that you're not going to accidentally put the needle into the joint to try to get the medication exactly where you want. In about 15% of patients, there's a communication between the joint and the iliopsoas bursa. So in some cases, despite taking care to do this in a technically correct way, you may still get injected material into the hip joint, and that may be unavoidable in some cases. But the important point is to orient that transducer in a transverse plane and be proximal enough to the joint. This is an example of one such injection. So you can see here we use the linear 12 megahertz transducer. The iliopsoas tendon is visible here. And using ultrasound guidance, we bring the needle in from a lateral to medial approach. And you really want to land on the bone just posterior to the tendon. So often we'll use the bevel a little bit to kind of steer the needle so that it touches down right where the bursa is. As you inject, you see the bursa fill. Often the tendon itself will rise up a little bit off the surface of the bone, and you may see fluid accumulating medially and laterally as well. One other thing that I mention to patients when we do this procedure is they may have a little bit of transient numbness or even a little bit of weakness in their leg afterwards. So it's a small percentage, maybe 10% of patients experience that, but we certainly want to make them aware of that before doing the injection, because that's a little bit disconcerting to find out after the fact. And we also ask that patients come with a driver to ensure that they don't have a leg that's numb and they're trying to drive home. All right, trochanteric bursa injection. So again, a common procedure. Patients have lateral hip pain. We're asked to evaluate them with ultrasound and potentially perform an injection. So here, in most cases, we're going to have the patient in a decubitus position with that side up and easily accessible. Again, depending on how mobile the patient is, we may modify that a little bit, but in most cases, we're going to use decubitus positioning. Whatever transducer is appropriate, depending on the body habitus, again, usually a high-frequency transducer if possible. Like the iliopsoas injection, commonly this is a combination of both a diagnostic and therapeutic maneuver. We're trying to get a sense of how their symptoms change with injection and hopefully make them feel a little bit better as well. Okay, so we start with just a diagnostic evaluation of the gluteus minimus and medius tendons, as well as the overlying fascia and the gluteus maximus. It's rare to see extensive fluid, so even if patients have symptoms that are really coming from that region, particularly the greater trochanteric bursa, you really may not see any fluid in that location at all. And again, it doesn't mean that they're not having symptoms referable to that location. So how do we do the injection? There are a couple of different ways that people go about doing this, and I think they're both perfectly fine. One of the nice things about the lateral hip is there's not a lot of vital neurovascular structures that we need to avoid, so there's certainly some flexibility in how we go about injecting the bursa. I find injecting from a longitudinal approach, coming inferiorly to superiorly, often works well. In that orientation, I can see the gluteus medius tendon, and overlying that, gluteus maximus, or the thickened fascia, and from there advance the needle right to that tiny anechoic space between the two. So if the patient does have a little bit of fluid, as in this case, it works really well. You can guide the needle tip right to the margin of where the greater trochanteric bursa lies. Often I'll do that with some anesthetic along the whole course of the needle. Once you get into the bursa, you'll find that there's a loss of resistance. You can inject fluid and see the anechoic anesthetic flow freely in that bursal plane. Sometimes even a bubble or two will get in there, and again serves an additional visual cue that you have the needle tip right where you want. I'll leave the needle there, take that syringe off, put on the steroid, and do the injection in that location. All right, calcific tendonitis lavage. This is not a commonly performed procedure at our institution in the hip. We certainly do a few more in the shoulder, but it's essentially just an analogous procedure to what's done in the shoulder. We do a mechanical disruption of crystalline deposit, and then typically we'll follow that with a therapeutic injection into the greater trochanteric bursa. Patient positioning, decubitus in some cases, and this one I'll modify a little bit. If at all possible, I like to have the syringe so that it's dependent in location to where the crystalline deposit is in the patient. The hope being that you can get a little bit of the crystalline debris to flow into the syringe. So sometimes we'll position the patient a little bit differently to try to accomplish that. This is an example of a patient who had some calcific density near the gluteus medius insertion. You can see well demonstrated here on radiographs. Corresponding MRI images show on these fluid-sensitive sequences increased edema in the muscle and in the tendon itself. So these are corresponding ultrasound images of the same location. And you can see the bright echogenic focus of that calcification, which is well demonstrated on the radiographs. Right here near the margin of the lateral and anterior facets of the greater trochanter. Here it's demonstrated in longitudinal view, and this is a reoriented MR image, just giving you an idea of where we have the transducer placed on the patient. So pre-injection appearance. Again, once demonstrated well with ultrasound, we guided a needle into the substance of the calcification, and again with a little bit of forward pressure, tried to fenestrate and break up that calcium deposit and aspirate as much as possible. And then again, we commonly follow that with just a therapeutic bursal injection to follow. All right, hamstring origin injection. Sometimes we'll inject around the hamstring origins. Recently we had a case where we tried a PRP, platelet-rich plasma injection, in the hamstring origin. So I just want to give you an example. This is one possible use of ultrasound in and around the hip. Again, we have the patient positioned prone. This is a patient who presented with left proximal hamstring pain. So on a fluid-sensitive MRI, you can see increased fluid at the origin of both the semimembranosus and that conjoint tendon from which the semitendinosus and biceps femoris arise. So these are the corresponding ultrasound images. I've reoriented the MR here to show the origin of the structures at a relatively normal appearance proximally, but coming through a little bit more distally into the tendon in the transverse plane, you can see this more heterogeneous echotexture, a little bit, few small areas that are more echogenic, perhaps a few little ossicles that are forming at that location. So certainly some sonographic evidence of abnormality at the tendon origins. Again, we're there with the patient, you can talk with them, and as I press with the transducer, I verify that this is indeed where the patient's symptoms are coming from. This is a corresponding sagittal image showing the origin in longitudinal plane as well. So before we did any injection, we certainly wanted to find out where the sciatic nerve was so that we could avoid that structure. So turning the transducer transverse to the patient, scanning down a little bit, identified that structure kind of superiorly and inferiorly, and made sure that we are away from that before we proceed with the injection. So again, transverse plane, abnormal hamstring origin demonstrated here. And then with sonographic guidance, approached that area and did our injection as well as fenestration of the proximal hamstring origin. All right. So to summarize what we talked about, again, ultrasound is really, in most cases in the hip, tailored to answer specific questions. So typically we're looking at an anterior hip pain, somebody who says that they have a snapping hip that's painful. A specific question like that is usually what we're going for. It's a highly adaptable technique, so useful in multiple diagnostic and therapeutic interventions. A couple other just sort of general points about ultrasound, which I've mentioned before, is you have the patient there. So I'm constantly asking them questions, making sure that what I'm seeing correlates with their symptoms. Sometimes we'll see some tendinosis or other findings that the patients may not have a lot of symptoms related to. So important to talk with them while you're doing the procedure. Another nice thing is you have the other side for comparison. So if things are confusing, often I'll image the other side as well and save images both in packs for the purpose of comparison. Just have a few quick acknowledgments. I wanted to thank Ken Lee, who's provided a lot of guidance to me in ultrasound from the University of Wisconsin, and also the sonographers at the University of Colorado who submitted to my scanning to obtain a lot of the images for this talk. All right, so we'll start with evaluation of the anterior portion of the hip and thigh. Just rolling up my sleeves here. So one thing important to mention to the patient, and I talked with our model here before the examination, is that often we have to expose a fair amount of the anterior hip. Of course, you want to protect the patient's privacy, but you'll find in some instances that you need to change your drape a little bit to adequately show what we need to see. So the way I'm going to start here is with the Curve 5 transducer. And again, I'll often start with this just to get adequate tissue penetration to make sure that we see everything we need. And then from there, go on to use a higher frequency, typically the linear 12 megahertz transducer. And again, the place I'll commonly start is somewhere I can really find an easily identifiable landmark. So here I'm quite a bit distal to the joint itself, and I'm just localizing right over the femoral shaft. From there, we'll move proximally into the region of the hip joint itself. So here we're getting to the trochanteric region and then up toward the femoral head. So you can see transversely oriented compared to the patient. Structures are still a little bit confusing. You want to turn into that oblique axial plane, as we call it in the MRI, or longitudinal to the femoral head and neck, and that'll bring all the structures appropriately into view. So here you can see the acetabulum superiorly. I'm pressing somewhat hard on the patient here to bring all those structures into view, but you can see the echogenic margin of the acetabulum, as well as the femoral head. Thin line of hyaline cartilage, not very well demonstrated with the low frequency transducer. We'll show that a little bit better with the 12 megahertz here in a moment. I'm going to come a little bit inferior to that, and here we are at the anterior joint recess. So you can see here in the normal patient, bright echogenic capsule and really no detectable fluid whatsoever. So that's the normal appearance. And this is the way that you want to look for any fluid in that location. The way I have the transducer here, you can see it's obliquely oriented. And if we're going to do an injection of the hip, I would keep the transducer again in the same location and then start more inferiorly and following the same plane of the femoral neck, advance the needle into the anterior joint recess. Okay, so let's switch to the 12 megahertz transducer. I think it's hiding behind that one. Thank you. So I'm going to look at some of those same structures, but just point out some of the differences in appearance. If we're looking at the iliopsoas tendon, often I'll use the higher frequency transducer quite a bit more here. All right, so identifying the same landmarks, kind of coming up into the hip joint itself. Here you can see we have a much smaller field of view, thank you, with the surface of the femur, thin layer of cartilage, capsule overlying that. As you come a little bit more superior, we'll get into the region of the iliopsoas tendon. I'll have you, if you can, just kind of pull up on your shirts there. Oh, great, thanks. Okay. So, trying to identify that structure right here. It's a bright echogenic structure, just superior at the bony margin. So again, you want to follow that structure both longitudinally and transversely over the hip. Bubble in that one. Okay. All right. So right here, a couple of the other structures that come into view anteriorly. Come a little bit proximal. Oh, I see. Okay. Good. So what I'm going to do is just sort of feel along the front here. Okay. So way high up is the anterior superior iliac spine. Again, I'm kind of moving the transducer way up, so not making good contact with the patient. A little bit further down, the anterior inferior iliac spine. So again, we can see the long head, and the indirect head is a little bit more inferiorly and posteriorly there. Thanks. Okay. So for injection of the iliopsoas tendon, again, going to want to land on that well-defined posterior bony margin right here. Okay. Let's have you go ahead and roll so that you're facing that way. We're going to evaluate the lateral hip. I'll let you clean up some of that gel there. So I'm going to adjust our depth a little bit. Okay. So again, you can identify where we're looking at just by palpation or finding the lateral margin of the femur coming proximally. And into view here, we're going to see the anterior facet of the greater trochanter. So I'm rocking the transducer back and forth a little bit, and you can see the degree of anisotropy that you can see if you move the transducer off plane a little bit. More laterally are the lateral and posterior superior facets, and you want to follow each of those up into the gluteus minimus and gluteus medius musculature along the lateral margin of the hip. If we're considering doing an injection at this location, again, in this patient, there's really no detectable fluid that you can see between the tendon, in this case, gluteus medius, and the overlying fascia lata. So it's right in that location you'd want a guided needle to do an injection. And again, typically I'll do that in a longitudinal orientation, as you see here, but certainly some practitioners will do that coming in a transverse plane as well. All right, let's do the medial hip next. So I'll have you go ahead and straighten out just on your back. Straighten out both legs, and then we're going to have you bring your leg kind of up and out a little bit. You can straighten your other leg there. So flex your knee a little bit and bring your leg out like that. Okay. So again, the structures that I'm looking for here are the neurovascular structures, and then the adductor musculature as well. And sometimes you may need to use a different transducer to show the adductor longus, brevis, and magnus along the medial hip. Follow those proximally to the pubic bone here, and then up into the rectus abdominis to make sure that the appearance of the overlying aponeurosis and fascia is intact. So potential site of injury in athletic pubalgia that you want to be sure you evaluate it if you're looking for that indication with ultrasound. Another structure to look at here briefly, I didn't mention the sartorius when we were looking earlier at the anterior hip. You can see that it's swinging all the way across the anterior margin of the joint. here overlying the femoral artery as the roof to that structure. So easily identifiable as that courses all the way down to the tibia. So that's a nice landmark that you can use to find that structure. Yeah, I can point that out here with the arrow as well, right there. And again, vessels are nice landmarks. They're readily identifiable everywhere in the body. So I'll often use that or bony landmarks to find the appropriate muscle structures that we're looking for. Okay. Then the last area we'll look at is the hamstring. So in this case, I'll have you just roll onto your stomach. Okay. So I'll start by placing the transducer, on the kind of mid-posterior thigh. Often by bringing the transducer up and down a little bit, some structures will really come into view. And you can see the appearance of the sciatic nerve here. Coming a little bit proximally as well, up into the ischial tuberosity, where we're going to have the origin of those structures. Okay, right here, you can see the kind of bony protuberance there, the ischial tuberosity. Again, you can palpate that area. I'm pushing fairly hard with the transducer to get adequate evaluation. And as you come a little bit distally, you can see the appearance of those tendons as they change. So this image right here corresponds to the semimembranosus, that conjoined tendon from which semimembranosus, from which we get semitendinosus medially and the biceps femoris laterally. And as you come further down into the posterior thigh, you'll see more and more muscle fibers arising from that conjoined tendon. And then deep to those is the sciatic nerve with that characteristic honeycomb appearance. And again, if you're doing any intervention in the posterior thigh, you certainly want to be aware of where that structure is. And I'll spend a fair amount of time looking at that with ultrasound, kind of visualizing where in the patient that is. And before we put a needle anywhere in there, want to avoid that.